Hi, everyone. Thank you very much for coming. This is the panel that's the executive session for short-term global health travel, good intentions, murky ethics, and how anthropology matters. And I wanted to first just say that we're actually recording this session as well as a session that we had on Thursday, which were designed to be put together and pitched as an executive session. And we had designed it to be back-to-back, where the first part was going to be about the empirical evidence that we have that looks at some of the murky ethics or things of concern in terms of different types of short-term global health travel. This was short-term medical missions, international volunteering in healthcare settings, international medical electives. And so that was actually a recorded session and should be going up on the AAA's YouTube channel relatively soon. And then this side of it, which got the executive session status, was really about trying to bring together really conscientious, anthropologically informed practitioners who've really thought about ways to be doing this kind of global health travel in ways that are much more sensitive to the murky ethics and more on a day-to-day basis thinking about how do we conscientiously engage. And so I wanted to first just thank Augustine Fuentes, who was the designer for this year's theme on Anthropology Matters and worked very well with us to try to set up this executive session, and also the executive committee for the consideration, because it's a topic that as educators and practitioners we come across a lot of people trying to figure out how do we create spaces of engagement across global health travel and training and this kind of thing that will actually follow ethical guidelines and be truly meaningful for all parties involved. So just a little bit on the Thursday panel, it included data from Tanzania that was my own on international volunteering in healthcare settings, from Botswana on international medical electives, and then two pieces on Guatemala by Nicole, who's here, and Caitlin, who's sort of close to the end. Those were on more short-term medical missions and the way that patients were trying to engage with foreigners who were coming to provide healthcare services. And all of that brought up a lot of really problematic ethics in terms of the way that people are engaging. And so this was really about hitting that part of the Anthropology Matters call to actually look at solutions as well, or models that have some promise that we could potentially collectively think with. So I'm going to invite Nicole Berry to come up and talk a little bit about our format for today's roundtable.
Thanks, Noelle. So what we are going to do for the roundtable is first I am going to introduce our long table of participants. Noelle introduced herself, and we do have two other participants beside myself from the panel who won't be talking as much but will be engaging in the conversation. So one of them is Claire Wendland, who's associate professor and associate chair and professor in the Department of Anthropology and professor in obstetrics and gynecology at the University of Wisconsin-Madison. And then also Caitlin Baird, who is a PhD candidate from the Department of Anthropology at the University of Florida, who's seated at the end. And so what I'm going to do is I will briefly introduce our roundtable participants, who are our anthropologically informed practitioners, and then I'm going to turn it over to them, and they're each going to give a brief around 3 to 5 minute introduction to talk a little bit about their work, and then we'll bring it back together, and we have a couple focal questions just to get conversation going among our different panelists, and once we get that going, then we're going to go to the floor and open up to the floor to take questions from you and hopefully be able to stimulate our discussion more. So I wanted to introduce you, first of all, at the very end, we have David Citron. And David is a medical anthropologist trained in global public health who's worked in Nepal since 2001. His early experiences as a medical volunteerist coordinating medical camps led him to critically re-examine the ethics and limitations of models of ephemeral healthcare. David is an affiliate instructor in the Department of Anthropology and Global Health and co-directs the Nepal Studies Initiative in the Jackson School of International Studies at the University of Washington. David is also the Director of Impact for Possible, an organization that partners with the government of Nepal to strengthen public sector healthcare delivery systems. Next, we have Jill Fleurier. So Jill is an associate professor of anthropology and the associate dean of the Honors College at the University of Texas at San Antonio. She's a cultural and medical anthropologist who works on issues of healthcare inequalities in the US-Mexico borderlands, northern Mexico and south central Texas. Jill was responsible for implementing a short-term Spanish and clinical immersion program for pre-health profession undergraduate students from UTSA with Monterrey Tech University and the Mexican Social Security Institute in Guadalajara, Jalisco, Mexico. And then we have Rafael Frankfurter. So Rafi was an executive director of the Well Body Alliance from 2012 to 2015. And the Well Body Alliance is a healthcare organization in eastern Sierra Leone operating a medical center, community health worker program, and health system strengthening work integrated with the Ministry of Health. Well Body was at the front lines of the Ebola crisis, and Rafi was the acting director and designer for the Ebola community health worker systems linked to a network of remote Ebola care centers across Sierra Leone, as well as oversaw the integration of partners in health into their programming. And he is currently pursuing an MD, PhD in anthropology at the University of California, San Francisco. And finally, we have Saskia Bunge, and Saskia is a Guatemalan physician with an MPH in community and behavioral health. And she works in rural southwest of Guatemala for Fund Salud Guatemala, which is a foundation that focuses on primary health services and health promotion. And the foundation hosts medical residents, physician's assistants, public health and pharmacy students from abroad for month-long rotations. So I will turn it over to you. Maybe we could start at the end with David, and we'll work our way back.
Okay. Well, first I wanted to start by thanking Noelle and Nicole for organizing this roundtable and the panel, which unfortunately I wasn't able to attend on Thursday, but I look forward to seeing it on the YouTubes because I think it's an incredibly important topic, and I kind of love having this conversation, so I'm really excited to be here. So thanks for organizing this panel. I think it's great. So I just had a few kind of ideas or comments I wanted to share based on my experience kind of being a medical voluntarist, so to speak, and helping to organize these short-term medical clinics in Nepal early on when I was first becoming a graduate student in anthropology. And some of the kind of ethical challenges and dilemmas that I've seen kind of permeate this growing phenomenon, and talk about some of the potential long-term consequences of short-term forms of ephemeral care. I think the first point I wanted to kind of highlight was, I mean, from an anthropological perspective, I think one thing we are well positioned and kind of trained to focus in on is identifying inequalities. And I think there kind of remains a very strong thread of inequality that exists in these kinds of global health engagements and opportunities, and tremendous asymmetry in the opportunities and benefits, as Susan Erickson and Claire Wendland have written about in an article called Exclusionary Practices. You know, as you see the kind of explosion of global health travel, global health electives, rotations, you might expect to see something called a get one, send one kind of approach where, you know, there's a one-for-one exchange, but that is rarely the case. Recently, for example, we had a nurse, a Nepali nurse that I work with at the organization, who received a fully funded 6-month academic training program to a reputable university in the United States, and helped crowdfund the remaining part of what she needed to go travel there after kind of, you know, she had been given paid time off by the organization, and we tried to support her in every way. Summarily rejected twice by the US Embassy for her visa to come to the United States. No explanation, and, you know, several $100s kind of, not to mention the time, gone down the drain. So I think one thing we really need to do is try and push our own universities, our institutions and organizations to really try and struggle for equity of opportunities as a prerequisite for kind of engaging in global health opportunities. One university that does this particularly well, I think, and one example is the UCSF HEAL Fellowship, which HEAL stands for Health, Equity, Action, and Leadership, and they really try and promote the kind of mutual opportunities for people, for example, getting to come to the United States, getting to be involved in fully funded master's programs in the UK and in the United States. So they're really trying to remedy this kind of inequality of opportunities and benefits, including social capital, which is also a major part of what these global health engagements bring. Another point I wanted to highlight was this idea of regulations and kind of the importance in global health engagements and short-term travel opportunities that often skirt around councils or governing bodies in quote-unquote host countries. I see this all the time in Nepal, for example. It is actually illegal to engage in any direct healthcare delivery on a tourist visa if you come to Nepal, which is primarily how most students and providers come to Nepal, because getting a non-tourist visa or work visa is incredibly difficult and takes months and months. So most people actually do skirt around that registration process. And I think one way that we can help safeguard against these maybe misinformed or ill-prepared opportunities from the United States side of things, for example, is to have IRBs potentially play a role here in evaluating the appropriateness of these opportunities, just like they do with research. We might be able to envision that they evaluate these proposals to go engage in global health travel on a similar kind of criteria, or a number of points that they look to evaluate the appropriateness of this. You could think about, is there a partnership in place? Are they able to speak the language, or is there a plan in place to be able to communicate with with people in the places they're heading? Do they have funding set up? Are they culturally humble, as opposed to the phrase culturally competent? I like cultural humility versus competency. And are they duplicating efforts? Are they proposing something that is already going on, and then maybe the IRB can kind of help link up these opportunities and efforts so they're not duplicating the efforts of other folks and duplicating the efforts of the local government, public health, and service delivery efforts. And I think maybe it could be time to talk about a medical volunteer or a global health travel code of conduct, similar to what we've seen with the NGO code of conduct that organizations like Health Alliance International have started to write, and the first author of that code of conduct was a medical anthropologist who's been working in implementation science and global health for quite a while. So really helping to kind of drive that there are principles and tenets in place to strengthen public sector healthcare delivery systems, as opposed to skirting them or undermining, which I think is sometimes the unintended consequence of some of these opportunities. And then I think one of the other things that anthropologists can bring to looking at these opportunities is some of the long-term research that can follow from them, kind of looking at the traces and afterlives of these engagements. What happens when people leave, both in the host country, what happens after the medical student, the volunteer goes back, and kind of looking at what unfolds there, both in terms of the disruption of healthcare delivery efforts, or for example, if what I often see with surgical camps, are there any post-operative complications, and really looking at the outcomes, but also kind of some of the social and political lives of medicines and how they circulate after people bring them there. And then I think, I don't know how much time, I've probably taken more than 3 minutes, but I'll end with maybe two kind of phrases that I like to think about in terms of, if there are two lessons to kind of inject into these opportunities, what might they be? I think one is this rethinking of the idea of better than nothing, something I hear very regularly from people who go to Nepal to engage in these trips is, I know they're just public health students, or I know, we might not have saved lives, but it's better than nothing. And I think really pushing back against this idea that nothing is what people are kind of presenting up to, it really does kind of quite a symbolic violence to already, the real efforts to deliver public health and healthcare delivery in countries. And the last one is, in all ways possible, try not to medicalize poverty. And I think a lot of these opportunities end up really seeing intervention as kind of what they should be doing there, the kind of biomedicalization of these global health opportunities, technology as ideology, and really trying to figure out if we are going to go and engage in these, how can we become involved in struggles around social justice and projects that lead to improved health outcomes that we know, for example, ample self-determined sources of food, clean drinking water, education for girls and women, things that might not be as hot in the global health travel scene, such as like e-health or mHealth are seeing a lot of this happening with medical volunteers, but trying to kind of take a step back and get back to the basics and engage in some of these broader struggles for social justice. And the last one I guess I'd leave it with is that, global health starts at home. So I think a lot of the students who come and ask us and they say, well, you've successfully bummed me out, now I'm rethinking if I should go abroad in this opportunity. And I think, one thing that we can kind of coach and steer students who are increasingly coming to us to ask how to do this right. Global health does start at home, and far often we go abroad to help people who we would so readily ignore right back at home. So I think kind of the reframing of the idea of global health could be a good starting point. So I'm sorry I took more time.
Fine.
Okay, sorry. So I would also like to start by thanking Nicole and Noel. I think I'm probably the only one that is mostly a clinician and then a public health specialist with an anthropological background, so I think I can speak more from experience of what I see on a daily basis by working with residents and doctors that come from the United States or students that come from the United States on a daily basis. The place where I work in is in the rural southwest of Guatemala, which is a place that is very interesting because it's a very migrant population, and so there's not really a sense of community, and so most of the time, even myself as a physician in Guatemala from the city, I have to approach it from the fact that I'm an outsider. And that's something that most physicians, even in the country, don't realize, is that as a position of a physician, you're coming at it as an outsider as well. And when I first started working at the foundation where I work at, I found it interesting that we were asking medical residents and students to rate their rotation. So that was the first thing that we asked them asked them to rate the rotation as an experience, and we were never really asking the patients what they thought about the services. So one of the first things that we implemented was very medical oriented. We started looking at reconsultations or revisits or follow-up visits to see if that had an effect between the doctors. But obviously that wasn't really what we had to get at. We had to start interviewing patients to actually understand what they were feeling from being treated by both outsiders who were physicians from Guatemala and also outsiders that were physicians and students from the United States. And what we really got to was the fact that we didn't really know the community as a whole as well. And so we started doing a little bit of different changes. As one of the things that we started doing was the first week that doctors or people start rotating through our clinic, they're not allowed to start in the clinic. They must go into the communities first. And so we have a community outreach program. And so one of the things that we started was if we want anybody to come close to appreciating or understanding the differences, we had to start with something that was visible. And so things that you could see were visibly different in the communities. A story I like telling was I had a pediatric resident telling a family that their child shouldn't be doing co-sleeping with them, which was obviously something that in the United States is given as part of the anticipatory guidance to pediatric patients. But that was something that in the community we were in was something that was completely irrational to be recommending. There's another one that I like to explain too is a pediatrician was trying to tell a family member that little kids shouldn't have bracelets with beads on them because they can chew it and, but that was an amulet against mal de ojo. And so that was on there. But those are very different things. One is a very visible understanding that there's a home with one bed and everybody sleeps in that bed. And the other one is an understanding of a culturally bound syndrome, which is mal de ojo. And if we want to get at explaining something like that to somebody who's only in the country for a month, we have to start by the visible differences. And so that was one of the things that we started was go out in the community, see the homes with our nurses. And that's, I think, one of the benefits that we have is that our clinic is fully staffed by Guatemalan nurses that are local. And even us as physicians that come from more urban places are constantly learning from the nurses and approaching that as a learning experience from the fact that we are outsiders as well because we come from more urban settings helps us a lot. But mostly the fact that we have an overwhelming amount of local nurses that come from the communities and are constantly teaching us. So I think one of the important things and engaging local physicians in the process of medical tourism is important because it's a rolling process for them as well. Making local health professionals responsible and involving them, because most of the time, even as health professionals, we come from a very narrowed view that any help or any medicine that comes from the outside is better. And I can say that for myself. It took me a long time because most of our training comes from medical journals from the United States and books that are written in the United States. And so most of the time we're approaching that is the best medicine and the best and the only medicine. And so you have to understand that all the doctors and health professionals in the country are being trained that way as well. So I think this, for me, specifically is more a learning opportunity from everything that you guys are saying that comes from a very different perspective, but I think informs a lot of the decisions that I think most of us should be doing as local practitioners involved in travel, because it's a learning experience not only for us, but for if we want to make the experiences, not the experiences, but make professionals visiting us do a better job for our patients, then we have to be informed as well. So, thank you.
2 microphones. Whoa. So this is my AAA debut, so I actually wrote something that I will read, a bit autobiographical, but I thought it might be helpful if I give a bit more background of my own trajectory in this field, as it has shaped my perspectives on how we might think of global health tourism as an opportunity to model how ethnographic engagement and the doing of global health can be profoundly interdependent. At this point, I feel somehow like a grateful but deeply ambivalent product of global health tourism myself. I entered college vaguely interested in medicine, culture, the intersection of the two, Paul Farmer, and service. In my freshman year, I became a part of a pilot project run by Joao Biel, in which small groups of students from multiple social and natural science disciplines were funded to conduct immersive research alongside local global health NGOs throughout the developing world over the summers, and then reconvene throughout the year for critical discussion, reading, and writing to think more broadly about the intersections of ethnography, critical anthropological theory, global health, and the burgeoning interest in the field on campus. I was linked with a small NGO called Wellbody Alliance in rural eastern Sierra Leone. My job that summer was to spend each day with people who had been maimed during the Civil War, resettled by a Norwegian NGO into, quote, amputee camps, and then largely abandoned after that. The amputees now faced widespread hunger and destitute poverty, and I had been tasked with trying to make culturally valid a PTSD questionnaire so that the NGO could potentially begin prescribing anti-anxiety medications with an anthropology postdoc. I remember well a first interview when a woman shrugged her hands up and swept them around, beckoning us to look at her crumbling toilet, children with bloated stomachs, her small subsistence garden, and said, "Our problems are on your desk now." I felt lost, implicated, shocked, appalled, humbled, and confused, but also motivated to develop these relationships more substantively and think about how I might maybe help. Over that summer, we were increasingly pressured by the American doctors running the organization to turn our findings into a medical program, and I found myself increasingly confronting the limits of medicine or clinical intervention within such a brutal socioeconomic context. As I became more deeply aware of the profound complexity of the amputee's condition and what an appropriate intervention could possibly look like, I also found a certain intellectual energy, along with my peers that summer, in cobbling together and crafting points of critique to push back on the reductive tendencies of the American humanitarian clinicians there. I bring this up because I think this energy and my continued commitment to anthropology and global health work came out of this initial volunteer experience and is also a possible response to the question that came up on Thursday: so how can we think about differentiating criticism and cynicism? Over the following 3 years, as I returned to Sierra Leone each summer to continue service projects for the organization and engage in ethnographic explorations, broadly surrounding the ways in which patients, healers, and health workers interact and make do amidst fleeting but promising sites of humanitarian care, in tandem with my wrestling with thinkers like Fassin, Wendland in particular, Petrina, Redfield, in and outside of my anthropology classes, I felt myself drawn to an ethnographic orientation that was not necessarily instrumental, but was one of trying to understand while doing, reflecting on the ethics and politics in which I was entangled myself, and of privileging the ways in which my immersive experiential travel could bring into view the limits and problematic assumptions inherent to global health practice, while also maintaining a commitment to enacting an agenda of global health equity. This is an anthropology that could open up creative possibilities for thinking about caregiving beyond the technocratic logics of much of global public health theory, skills and orientations that deeply influenced my subsequent work during the Ebola outbreak. After college, I became the executive director for the organization, strengthened ties with partners in health, and established short-term volunteer relationships with a number of medical schools across the US. By 2014, we were one of the major community health organizations in Sierra Leone. One position I took as a director was that in developing and staffing our international volunteer programs, we could privilege both the concrete skills and services volunteers could provide, whether they would, quote, add value, as public health wonks like to say, but also recognize that there is value inherent in facilitating the type of critical ethnographic engagement our volunteer program offered in shaping undergraduates, medical students, and residents to be more complex thinkers and global health practitioners. And I'm happy to speak more concretely about how we selected volunteers, structured our program, supervised them, et cetera. I was in Sierra Leone when the first Ebola cases spread to the country and subsequently worked with Sierra Leonean colleagues to design and manage Ebola community health worker systems attached to remote Ebola care centers that might be more attentive to communities devastated by the disease. Reflecting on it all, I obviously in no way feel like I've transcended the uncomfortable optics, logics, ethics, and politics implicated in global health work and my own desire to work in this field. But it was certainly through my undergraduate anthropology education and global health fieldwork that I learned to feel comfortable wrestling with them in real time, voicing them, and envisioning what could constitute a more people-centered, politically engaged global health practice, in this case oriented towards the Ebola response. So I'm left wondering, after the set of papers on Thursday morning, what, if anything, is substantively different between my trajectory and that of one of the global health tourists that were described, and also how fundamentally does ethnographic travel and global health tourism differ? I've personally observed and managed 50 to 70 short-term clinicians and have seen inappropriate behavior, savior complexes, simplistic worldviews reaffirmed. I've fired a number of them. But I've also seen how these stints can bring into view the profound messiness of real global health work and the need to attend to the complexity of individual patients in public health management, and the limits of humanitarian medicine in resolving complex, fundamentally political and structural disparities, in addition to saving real lives. For one thing, we might consider how context matters. In the region in which I work, there were 2 doctors for 600,000 people. Clinical volunteers, in that sense, were not really displacing local health workers in the same way as some of the papers that we heard. And I'd argue they actually constitute the system that patients navigate and have their own ways of critiquing and theorizing and making do through fractured sites of medical care and chronic illness that endures. And I think of this as sort of what you mentioned as the shadows that linger after humanitarian volunteers leave. Second, I think these programs, even when only 6 weeks long, can be structured in a way that productively bridges critical pedagogy and insights from social sciences to shape, but not necessarily burden engagement. And finally, a point I'd like to bring up, and I only truly came to appreciate as I found myself thrust into Ebola management spheres, is the pervasive consequences of the utterly apolitical and technocratic orientation and epistemology so inherent to much of global health practice. This is what I spent my intellectual energy and time countering during the outbreak, not just American humanitarian cowboys, though there was that too. The irony, it seems, is that global health travel can either reify this reductive worldview or challenge it, and I wonder how we might think about further reclaiming the short-term health trip as an opportunity for training in ethnographic sensitivity in the limits of humanitarian logics of care.
I'm going to echo my thanks. I'm thrilled to be here, and I'm already learning a lot. So what I'd like to talk about is a study abroad program in Guadalajara, Mexico, that I co-led year before last, and it definitely can be categorized as clinical tourism per Claire's definition. We were a small group of 8 women, undergraduate students and 2 faculty, and we spent 4 weeks in Guadalajara working with the medical school at Instituto Tecnológico de Estudios Superiores de Monterrey, or Tec de Monterrey, and their affiliated teaching hospital, which was part of the Mexican Institute of Social Service. The first week we spent in Guadalajara was intensive medical Spanish training, coursework in cross-cultural ethics that I taught or my co-lead taught, and clinical skills training taught by the faculty at the medical school at Monterrey Tech. The last 3 weeks included clinical interning at the teaching hospital. So Monday through Thursday, 5 hours a day, we went to the hospital where students worked with nurse teams with physician oversight, delivering primary care, well woman care, and emergency care. Our students worked alongside Mexican medical students who were the same age, and that's because in Mexico you start medical school right out of high school. So while our students were pre-health profession students, they were working with Mexican medical students. I should also note that Mexico works off an apprenticeship model, and so they put their students immediately into either teaching hospitals or clinics. If not the first semester, then definitely by the beginning of the second year, so they're 19, 20 years old. After clinical interning each day, we returned in the afternoon to the Monterey Tech campus where we had our seminar in medical anthropology, where we targeted topics of American and Mexican healthcare systems and inequalities, humanitarianism, and medical ethics. It was largely a structural competency model plus a little med-anthro, because these were students that were coming from public health, either the EPI track or a community health model, med-soc, medical anthropology, biology, psychology. And every clinic day, students wrote an academic, reflective, analytical essay that connected course concepts to observations and interpretations of their clinic experience, which were then peer-reviewed by at least one other student, and then they received feedback from myself. At the end of each week, they had to then tie together all of their reflective essays into a synthetic critique. Each Friday, we spent the day in clinical skills training at the medical school, which I mentioned were taught by their faculty. So 2 things struck me about our experience compared to what I've read about in the clinical tourism lecturer. So borrowing from Claire and also Julie Livingston, our students' moral maps were different than other clinical tourists groups, largely because of our students' relationship to Mexico, and also our university's relationship with Mexican universities and federal agencies. These moral maps were deeply connected to the chronotypes per Betsy brought on Thursday, the students' narratives about what they were doing, where, and why. And we saw these change through their academic essays over the 4 weeks we were there. The second thing that struck me was that despite our somewhat unique positioning, similar ethical issues arose nonetheless. Let me get to our first point, our positionalities. Our programming was more in line with medicine's recommendations for global MSTs and structural competency med-ed curricula. Institutionally, though, it's really important to note that UTSA does not have a medical school, and our students were undergrads. UTSA is also an HSI, or an Hispanic survey institution, with over 40% first-gen in college, the overwhelming majority of whom their parents are from Mexico. And our UTSA Guadalajara students were all first-gen. Half were heritage Spanish speakers, and half had family in Mexico that they regularly visited. As their instructor, I'm from the US-Mexico borderlands, did my dissertation work in Mexico, have collaborated with Mexican anthropologists, and work with Mexican immigrant communities in my research in the borderlands. Now, at an institutional level, UTSA has an MOU, a Memorandum of Understanding, with Monterey Tech. We do have faculty and student exchanges. And finally, UTSA houses a new higher-level partnership between CONACYT, the federal research funding organization in Mexico. We can think of it as similar to NSF, and the University of Texas system. So our moral maps then were imbricated in complex experience near pasts and places that perhaps are not as commonly represented in the clinical tourism literature. And those moral maps really shaped the students' responses to the common ethical challenges that, of course, did arise, including being asked to perform clinical work they were entirely untrained for, and or working in situations that were already scarce in time, resources, expertise, and materials. Thank you.
Oh, we're already live. Okay, thanks so much for that introduction. I wanted to say we did have one of our panelists from Thursday, our last one, join us. This is Betsy Brada. So I was going to start this off just with a continuation. I feel like Rafi's the one who touched on it most directly, but I wanted to take up and hope everybody would comment on this topic that came up at the end of Thursday's panel about the value of critique in informing or reforming global health travel. It seems particularly pertinent because anthropology is a critical discipline that's predicated on unpacking and interrogating ideas and practices that are frequently taken for granted or not questioned in other disciplines. Yet critique is often interpreted outside of anthropology as negative or obstructionist to action. And so I'm hoping people can talk to that point. And maybe you guys do find that it's negative or obstructionist to action too. So I hope you can talk to, is critique useful in your practice? How is it useful? And if it is, why is it useful? any of you?
I'll start,
Okay.
but I'll be brief. I think with respect to what I'm doing, so my other hat is the Associate Dean of our Honors College, where 85% of them are from the College of Sciences and Engineering, overwhelmingly pre-health profession, pre-med students. And I'm sure everybody has similar demographics in their honors colleges. And many of those students want to go on clinical tourism trips, and we have some that are almost entirely unsupervised. And so the way in which I see anthropology critique informing practice is that anthropologists and related social scientists have to get involved in these. They need to be the faculty leads, they need to be the faculty sponsors, they need to be in the forefront of their pedagogical discussions. I also think that the critiques that we have heard about global health travel are very similar to the critiques about service learning when you're working in your cities and your communities with anthropology coursework as well. And so I think there's a broader discussion that can be had across disciplines at each university in terms of how we structure community-based pedagogies, which is in large part what I see this to be.
I also agree that the value of anthropological critique in what we do is very, very important. And I will say that as a physician and somebody that's working in the field, I understand how, if you're not used to critique, and especially in Latin America where we don't take or like taking critique that easily, it can seem very negative. It can seem very offensive to begin with. But when we looked at our patient interviews, we realized that most of the time patients didn't reconsult or didn't come back for follow-up visits. It wasn't monetary. It wasn't the fact that they didn't have transport. It wasn't any of the barriers that we normally assume people have. We talk about barriers to access to health, and it wasn't anything related to that. It was the fact that they didn't feel understood by their physician, and that's something that as clinicians, as providers, we really can't understand if we don't have that anthropological critique to what we're doing. And so that became very, very apparent when we interviewed patients, that our assumptions of what the barriers were definitely not the ones that patients had.
Thanks. Yeah, I think, yes, I think the critique is always I can say from experience, having walked into lecture halls of providers, clinicians, doctors, as a non-clinician, you're often not very welcome. They often kind of see our ethnographic vignettes or details as, interesting or quaint, but not necessarily enough to drive kind of the changing of policy or approaches. But kind of as you were just saying, I think some of the broader questions that we can ask about outcomes, about these kinds of interactions, help kind of elucidate, those unintended consequences of these engagements or short-term trips. I can think of several from Nepal, or even just how anthropological the upstream thinking that I think we're trained to do can often help identify, ways where people can kind of meet in the middle, everything from, you were talking about the amulet that had, significance. I remember there was one health clinic that was set up in Nepal, and there were pediatricians from Austria who kept trying to get young children to take albendazole tablets, worm tablets, very useful, but the color during that month of the pill happened to be inauspicious. It was as simple as that. None of the parents would provide their children with this pill because it was red. They had a generic tablet in the back. It was, a different color, and they brought it out, and all of a sudden, children were being given this. I'm hesitant to use that as an example because I don't want to say we should be using kind of our anthropological insight to overcome cultural barriers in order to deliver care. I think this is where the cultural competency kind of runs aground as opposed to humility. The idea that culture is something you need to understand, kind of, shift a little bit, and then you can overcome it in order to deliver good healthcare. But I think kind of the pulling back and trying to understand plural approaches to healing. The idea that, I think there's a lot of conflation of health and healthcare often in the global health short-term mission engagements. So kind of trying to understand that even outside these clinics or people presenting to you during your medical treks or whatever the model is, kind of that is just one node in the kind of complex, patterns of resort that people are attending to try and seek healing. So kind of helping differentiate between some of these categories like healing, treating, curing, because I think they are very different. So hopefully, I think there's room for anthropological insight in there as well.
Yeah, I think, as I mentioned in the thing I just read, I've always found the close integration of critique and practice like a profoundly energizing experience, intellectually, personally, professionally, the way that they can be dialectical. And so I was reflecting on that after the panel on Thursday, and one thing that I think is important potentially, although I'd be curious in hearing everyone's response, is kind of separating as the object of critique the politics and structures in which actual humanitarian practice takes form from the underlying sense of humanism that is inspiring an unprecedented number of undergraduates, medical students, and residents, doctors to want to help in the world. And part of that, I think, is reckoning with the real effects that Paul Farmer's political consciousness kind of entering with some sort of mainstream global health discourse on campuses, like a political consciousness that somehow situates our relative privilege as deeply entangled with the poverty in much of the world, you know, what that engenders. And so that would be my initial response, is kind of how can we disentangle the desire to do good in the world, to engage and resolve suffering on the part of students and medical practitioners, from the very complicated ways in which such humanitarian activities take form, and the kind of engaging and exciting way in which ethnographic empiricism brings into view the messiness of how that works.
I don't know if anybody wants to. I don't know if anybody wants to respond to that. I mean, now that you're talking about this, Rafi, I was hoping maybe you could go back. Both you and Jill have experiences of doing some sort of curricular development. And I guess, Saskia, have you guys done curricular development then afterward? So maybe we can hear a little bit about what that looks like in terms of some sort of structured, guided approach to reflection in places where you feel, and I don't know if, somebody used the word structural competence, so I don't know, and then I'm hearing Rafi say, yes, we need to be aware of the structural issues and barriers. So is it just unpacking those sorts of issues that are going to be the focus of the curriculum? Are those the sorts of successful approaches, or what is it that you guys have found as being instructive or limiting in terms of coming up with these curricula around global health practice?
Well, so I can talk a bit more concretely about the volunteer program that we ran, if that would be helpful. So as part of our application process for medical students and residents who were interested in volunteering with us in Sierra Leone, we would first do an interview, an initial screen, and then our main application was a set of 2 or 3 really complicated ethical quandaries with no right answer, like really the murky ethics of global health. Well, I can give some examples if people would be interested, and see what their response is and how they think through it. And in general, what we were looking to avoid is people who were kind of overly dogmatic and polemical in their responses versus people who were able to wade through uncomfortable ethics in a way that seemed somehow sensitive and complicated to us. When people came out and worked with us in Sierra Leone, if they were clinical volunteers, there would be kind of 4 components to the experience. The first would be service to the organization, and that often involved direct clinical care within the district hospital, as well as before I say that, part of our orientation was a pretty substantial set of readings, some of Wendland's, some other critical humanitarian pieces, different things that, various theses that undergraduates who had worked in this region had written on complicated cultural, social, historical context. So we really primed people with the type of critical thinking that we were expecting them to perform in their work. So then when they got to Sierra Leone, there were kind of 4 components. There was service to the organization, as I mentioned, or direct clinical care. There was training and partnership with local clinicians. we had a couple long-term partnerships that introduced whole new services like ultrasound to the public health system, which was pretty incredible. And then we would require everyone to have an immersive community experience with some regularity that usually involved going out with community health workers and seeing the socioeconomic conditions in which patients lived. And this was where I really saw some productive and generative synthesis of thinking about where, what the limits are of clinical practice in a context like this. And then finally, we all lived together and we would have nightly discussions and continued reading and engaging questions about structure versus agency, what we're doing when how we're processing, you know, the various theory and readings that they had done before and during the experience. So that was how we kind of thought about producing a program that would kind of wed critical pedagogy with the goal of producing complex, nuanced global health thinkers with the actual service that they could provide.
Okay. What we did as part of our curriculum when we have residents or students come over, so we did two things. One was work with the social determinants of health, and the other one's capacity building. So the first one is we did, you know, what I had mentioned before. The first week was spent in the field with our community health workers or community nurses visiting homes. They do home visits with pregnant women and with children as part of our programs, and so the residents could watch and see. And so there's always a discussion about what they saw and how those determined health and how they had to modify most of the education or the, you know, plans that they gave, the treatment plans to patients based on what they saw. But I think the most important element was the part where we had residents come and we took their knowledge in capacity building. And so we took residents and we created lists of subjects that our nurses felt they needed training on. And these are community nurses training Guatemala and also our local physicians, things that we thought we were lacking in and probably the residents from the United States had just been trained in. Especially pediatrics. So something that was very good, for example, we had nurses take pictures in the field of dermatological concerns that they had, the patients came with. And so there was many times, then we created a curriculum based on what the nurses needed, and the nurses were taught how to treat these things from home. And this was something that we used the volunteers to teach the nurses different subjects that we might have not dominated or might have not been experts in. And so we use the residents back for capacity building in things that locals identified as concerns or that they lack knowledge in.
So I'm going to talk about what I didn't like about my curriculum. So the academic reflective writing, daily and weekly, I thought it did work. The cross-cultural ethics and humanitarianism and med-anthro content was good, but way too late. It needed to happen earlier. And since that time, I've learned more about these study abroad and study away courses and pedagogies where you connect it with a semester on campus, and you also do community-based experiential learning that's similar to what you will be doing abroad, so it makes the connections with your own community. And it also allows the students to have time to digest and understand what's going on and how it's going on. The same thing happens, I would say the same thing about our clinical skills component. It needed to happen before the students got there. And so if in fact, I put the program on hiatus for a little while to try and figure out how to address these because we had the right components, but we had them in the wrong order. I think the other thing that really struck me when I was down there is that we were doing a full ethnographic immersion experience. We were living in a medical school campus, we were participating with the medical students, we were being taught by their faculty, but we didn't get the patient perspective. And that's because, of course, in Mexico, as in the United States, there are huge power differentials between the doctors and the patients, particularly in the EAMS situation. And also, less so, but still there, between the nurses and the patients. And the patient's point of view wasn't being solicited, as far as we could tell, with respect to how the medical students were doing at all. And I don't know how to introduce that. I don't want to say, hey, by the way, I think going out and visiting the community is an excellent idea if they already do it. If I go down there and ask them to do it, that's just more time that they don't have, even if there is compensation for it. And it's staff that we're taking away from an already understaffed hospital. So I'm not sure how to bring that in unless it already exists. And again, it may in some degree or form that we didn't see and that we weren't privy to, but it's certainly something I would change in the future.
So I kind of wear two hats. I do research looking at the effects of global health travel in health facilities in Tanzania, and in the case of the research that I've done, it's not the prettiest picture, but I'm also leading a program myself, or have done for several years. It's also on hiatus for some of the common issues Jill deals with. But to get at that sort of combination of critical pedagogy with reciprocity and practice, I think what we did in Tanzania was actually quite great, and it required a lot of resources to effect well, but I think anthropologists are in a very unique place to be able to do something meaningful in this realm. So in my case, I'd been doing research in the Tanzanian healthcare system for several years. I had very good connections to people in particular parts of the country, and so I was able to navigate partnerships with Tanzanian entities that would enable us a space to be able to develop a program. And then I told my university that I wasn't going to do a study abroad program looking at, in this case, it was going to be community-based health research on topics that local community leaders had decided they wanted to learn about more or better. I said I wouldn't do it to my university unless they made spaces for 4 undergraduates from the University of Dar es Salaam. So they funded the Tanzanian students to come, and I found that the best match-up in terms of the type of training they had was actually the medical sociology program in the Department of Sociology and Anthropology at the University of Dar es Salaam. They were very happy to work with us on that, and also there was sort of some low-hanging fruit in that the conception that I had was, let's get these students outside of what I was seeing with the volunteers, which was doing interventions on patients that were well beyond the standards of adequate care because they didn't know what they were doing, and actually move them into doing something that at worst is benign and a very good experience in terms of meaningful collaboration across differences, and at best may give the local governments and local healthcare workers some information that they could use to improve their own understanding of the community that they're serving or improve their own practice. And so the low-hanging fruit was that the medical sociology students had actually had a qualitative methods class during their curriculum, and my plan on the Northwestern University side was to provide a qualitative research methods class also, where we talked about ethics of community health research and just thinking about more critically understanding power differentials across different things. So the Northwestern students who went on the program were required to take a methods class with me or my colleague Peter Locke at Northwestern, and then they went through a rigorous process of interviewing to ensure that they had a sense of the messiness of context and were really going to go into it with much less of this very static view of poverty is the same everywhere, and much more about understanding nuances of context and being humble about that and wanting to collaborate across differences. And then we left it to the University of Dar es Salaam to select the students that they wanted to have come along, so they had their own criteria and selection process. And then they actually were put into teams of 1 or 2 Northwestern students to every Tanzanian student, and they would come up with I would give them the topics based on the topics that were selected by community leaders where we were working, and then they would put together a proposal design, and I helped them improve those and understand how it would map onto that context, and then over the following several weeks they would do it together. The Northwestern students also had a language training program in Swahili. Swahili is one of these languages you can actually pick up quite quickly. It's a relatively straightforward thing. You can learn standard greetings and how to have a conversation with people in about a week if you've got a good teacher. And so they were actually pretty proficient language-wise, at least with conversations within the first 2 or 3 weeks of the program. And overall, the things that I would change, I would definitely, I think one of the challenges with doing these kinds of programs is the amount of time and toll it can take on the people that are trying to coordinate all of that. It's something that's so familiar to you and the students. It's their first experience, and with the Tanzanian students as well, trying to get them to feel at home, to engage with these foreigners that were coming in with whom they were living on a day-to-day basis was a challenge. Often the Tanzanians underestimated the quality of their own training, which was often far superior to the training we were able to provide at Northwestern because ours is interdisciplinary training. But it was hard to get the students to sort of own their own expertise and their own training, and take their spot as an equal in those partnerships, even when the students they were working with from Northwestern were really asking them to what do you think about that? Oh yeah, it's good, always without a lot of critical feedback. So even I think the best laid programs that really work on reciprocity and equity, often that's hard to achieve from the different players coming involved. And a lot of times, students, if you're working with students from the hosting community as well, it can be challenging for them to find their place. And I haven't quite figured out how to work through that, because there's a lot of interesting hierarchies there as well, where you never question a professor in Tanzania. There's dynamics of you always respect your elders, you always respect guests, and it was hard for them to sort of get comfortable. So I never quite figured out how to navigate that either. But it was something that everyone got a lot out of, and I'm gonna get off my soapbox now.
So we have about 45 minutes left, and I had said we were going to also open it up to questions. So I have more questions, but let's see if there's anybody who is among our audience participants who would like to ask a question. And if you would, I would ask that you go to one of the microphones so that everybody's able to hear. Yes.
Thank you so much for this panel. I have actually, now I'm wondering why in the world I ever did this, but a group of students came up to me and said, we're going to go on this medical global health brigades. We're going to go on this global health brigades thing. We've already got the wheels turning. Do you want to be our faculty advisor? And I was like, okay, so I'm a medical anthropologist, but I've never done something like this before, and I've navigated my own complex relationships and my own research and stuff, but these are health science students, pharmacy, physical therapy, occupational therapy students, and what I understand is there's a pretty robust infrastructure with global medical brigades, but I was just wondering if, any of you had any experience with this organization, if you could give me any pointers. Unfortunately, their curriculum is such that they won't really be able to. I'm teaching a global health class in the fall, but none of them will be able to take it. So I'm going to do a quick and dirty cultural humility seminar. They're going to go to Nicaragua. Let's talk about some literature, but any advice you could give would be wonderful.
Very short things. Yeah. One just very short piece that I recommend, and maybe you've read it, and then I'll pass it on. But there's a great, it's not an article, but it's been put in print. It was a speech given by Ivan Illich in 1968, so incredibly prescient. It's called To Hell with Good Intentions. I like to read it every few months, and it's a beautiful piece, and it was, if you don't know about Ivan Illich, he's amazing, and this piece is really, really great, and it is one of those ones where at the end it's pretty short, students are just like, oh man, but it really encourages us to kind of willfully give up the privilege we have to go and kind of spread our benevolence around the world, but yeah.
I think it's really important for students to understand, even before they get there, that their perceptions coming in can actually influence the organization that they're going to. So it becomes a case of sometimes if students go in expecting to see a certain kind of person, and those students are bringing money into that organization, then it becomes a sort of donor-driven chaos that can change programming and actually ensure that some people don't have access to care. So I think that's an important thing to start thinking about before you ever put boots on the ground. So probably the two texts that I would recommend for thinking about that seriously, and I think they're appropriate for an undergraduate audience, would be Mark Schuller's Killing with Kindness, of course, and Vincent Adams' Markets of Sorrow and Labors of Faith.
Does anybody else want to?
If I can jump on that Vincent Adam tips, excuse me. If I can jump on the Vincent Adams tip, sorry, that's hard to say. This isn't so much a text as a recommendation for a question to ask them, and that is, what are the metrics that they implicitly think would be useful in assessing what it is that they think they are doing, right? So, at least in my own research, there's a lot of attention paid to how close did you get to somebody's body, right? What kind of body was it? What kind of illness was it, right? I think in her discussion on Thursday, Claire Wendland gave us her undergrad's ranking of sort of the most suffering body you can touch was it deworming the Somali orphan, right? Okay, right. So these are things I think it's really worth helping them try to make explicit to themselves before they go, right? Would it be enough to watch somebody do physiotherapy or pharmacy in a really different place, right? Would that somehow feel like they'd lost out, right? And why? What are they losing, right? Because I mean, at least I might do my research in Botswana and was looking at a program where advanced medical students were coming through on sort of 6 to 8 week rotations, and one of the things that made them very anxious was a sense that they might somehow lose out on something that they needed to get. Right? And they weren't always entirely sure what that thing was, but it made them anxious, and their anxiety, I think, contributed to a phenomenon we've all seen, which is people overstepping their clinical training in ways that approach injury.
I'm just going to step in here as well, because I've got a lot of sensitivity about, as faculty members, that if you do any kind of teaching in medical anthropology or global health, you're often asked to do that kind of service as the faculty advisor. And a lot of in my experience anyway, some student groups are much more willing to come to you and have you help them think through these things than others are. And I think I want to be really sensitive to the structures that inform how students are thinking about those experiences, right? Because it gets very easy through the criticism for students to feel like they're being attacked, and that's not really where we're going to get them to think a little bit more critically about what's happening. And when you always get a flattened understanding because of all of the advertising and the discourses that are so familiar about places that we tend to other in our media and our daily conversations, and the issues of white supremacy that are sort of seem to trickle through a lot of things and are a big part of our discourse right now. I've found that our students really don't want to engage in that and are really trying to figure out how to do it right. But there's two major barriers. One is that an organization that is a national organization that has these student chapters, the presumption that a lot of my students have is that the chapter's done all the research, so I can plug and play. And what I can tell you about this is there tends to be on the part of these, now I'm not speaking about, my research is on private for-profit volunteer placement organizations, but the organization you mentioned and several others are of a slightly different type because they're partially student run, but there's a national sort of office that helps direct things, right? And so in those cases, a lot of times they're saying, okay, here's what the needs are in this place, and here's how students can make a difference and save lives, and here's the fundraising we need you to do. And they meet regularly. So these are students that are really trying to they're doing labor to try to make this good. But one specific example I have, I was invited to give a talk to sort of provide that critical lens on some of these things with 3 really conscientious student groups that will remain nameless. And one of the students had done a talk. He didn't speak any Spanish, but the public health talk he was supposed to give was provided to him in Spanish, and he read it to a community. And he was relaying this example, and he said, you know, it was telling them how to boil their water. And I just think about how many lives I was able to save just by a simple hygiene intervention. And my response to him was, do you know whether or not those people boil their water? And often, like, making those things into a bit of a thought problem helps them understand that messiness that they take for granted, because an organization that they trust is telling them this is what you need to do. And instead, he was like, well, no, I'm not really sure. And then, you know, the next question is, what do you need to boil water? Right? And then you let them sort of come up with the things. And of course, you need a pot, and you need access to water, and you need fuel, and you need something to light that fuel. And then I said, have you ever tasted water boiled on a flame? Right? And then you sort of start an opening of a conversation where you create just little dilemmas to help them realize it's a lot more complicated than what we presume, and also to empower them to feel like they can hold some of these organizations responsible as well, to be able to say, tell me what data you've collected that demonstrates that this is a needed intervention in this place, for instance. So trying to help them feel empowered to hold some of these national chapters accountable, because those national offices make their money from the activities of those students, right? So if you hit that market by helping them to be a bit more critically engaged, we might be able to do some things on a more structural level to improve the way the wider national organizations are really designing some of those things.
Can you go with them? Because I don't think faculty always go, right?
You know, I think I can, but I don't know how that works. I have to communicate with Global Medical Brigades about that, because I think they have to fundraise for their own own passage there. So,
Or your university could cover it. I mean, that's what I think. Somebody like you needs to be there.
with them,
Yeah.
yeah, with the little ones, yeah.
Yeah.
I also don't know that all of these organizations are so open to that.
Right. Yeah.
Oh, interesting.
Maybe Brigades is, but
Okay.
I'm not sure.
You might just check out with your students. I mean, they did ask you to be their advisor.
Yes.
They may already have some questions and critiques that they're not fessing up to you, but that you can open the door to. A lot of times, I mean, I have not been brave enough to take students on one of these, so this is theory talking. But I do teach a lot of pre-meds, and they often have critiques and questions at the ready. And if you can open the door to that, they can have fabulous conversations that are directed by themselves. So
That's a great
you
idea.
you can say something like, you know, previous students who have gone on these have really reflected afterwards about what their expectations were and how those shaped what they saw. So I wonder for you, if you were told, like, you couldn't Instagram anything, you couldn't post anything to Facebook, and you couldn't write about this in your med school application essay, how would your project look different? And let's brainstorm this together. And then, and so what does that mean? Right? And you can actually, they probably have some thoughts about this, and peer pressure works a lot better than pressure from us does.
So true.
I have one last comment just on the mitigating harm, because my work is on short-term medical missions, so there's a lot of people, it's a mix of clinicians and people who I guess you consider pre-health or have no health ability or clinical abilities like myself. So I have been in numerous situations where clinicians ask me to do things that I have no training to do. And people are very comfortable when I put the boundaries on. But I think a lot of what goes on in these areas, or in short-term medical missions in particular, is that everybody's going for an opportunity, particular people who are thinking about being doctors, and so there's a little bit of mentoring and shepherding, but those are open. There's nobody who's trying to get you to take blood pressure. They're not like dead set on you taking the blood pressure. They're giving you an opportunity. And I think that if you're not primed to understand that you have to have some ethical reflection in your own mind about what's acceptable practice and unacceptable practice before you go, then you're able to put those limits, because no one's going to push you to give anesthetic to somebody. Nobody's going to make you take blood pressures, temperatures, draw blood. But, well, I don't know, make you. But you get offered tons of opportunities, and I think it goes back to the vetting point that somebody said, we assume that if I go with this organization, I assume that the parent organization has vetted this opportunity. What I see happening in mission settings is that people show up and they assume that whatever they're being asked to do has been vetted in some sort of a systematic way. And so that is not what always happens, because there's a lot of chaos on the ground. So if people know what their role is in that question of what would you do if you couldn't write about it for your medical school, or what would you be comfortable doing, what do you do in your everyday life? If you know what that role is, then you can limit your participation to things that are ethical for you to engage in.
I'd say maybe one last thing to consider reading or kind of talking about with students before we go, or before they head off, is kind of the idea of, kind of thinking about population health outcomes, for example, and kind of should, for example, people from the United States be going to other places to teach other countries how to improve health, because, as probably many of us sitting in this room know, amongst all the quote-unquote industrialized or rich nations in the world, the United States is kind of declining in terms of life expectancy, and what an advisor of mine, Stephen Bezruchka, refers to as the health Olympics. All right, and he's kind of become obsessed with this idea of population health, and why, as he phrases it, no one pays attention to why people in the U.S. are dying younger than they should. But this question of, we haven't quite figured out what causes good health outcomes necessarily in the United States at a population health level, both in terms of looking at rates of maternal mortality, child mortality, and so are we the right ones to be going off and kind of teaching other people about how to improve their own healthcare systems? And he has this great phrase which flips the kind of this well-known motto on its head. He says, we should really be asking ourselves, or telling to ourselves, don't just stand there, do something. He says we need to invert this, and it is, don't just do something, stand there, comma, unless it's very obvious that doing something will help. And he gives this to medical students, residents, public health students, and he delivers it in a great way. But I think just kind of the pulling back the picture from, are we the best equipped to be going, and kind of that bidirectionality, and kind of what people often refer to as kind of reverse innovation, or kind of, which is a really pejorative way to phrase it, but really thinking about what kind of lessons can be brought back to bear on our own, healthcare delivery system.
Healthcare system, yeah.
$9,000 per capita isn't quite getting us to the outcomes we need. So should we be going to teach people how to do fee-for-service healthcare, or kind of other very strongly interventionist approaches? So.
And just very quick, and this can be an insanely painful thing for students to hear, but I think it's also very useful too. It's important for students to kind of interrogate, to pull back even further, and to interrogate their own positionality in terms of who they are and what they're looking for, because organizations like Global Health Brigades, even nonprofits, require capital, and so many times, missions like that are so much more a product that is being packaged and marketed to students and to the people who are going on these missions than it is something that is being sold or marketed to the people who would be receiving the services. And so if you reframe the conversation about this, you are not going there to teach, you're going there to learn. You are not going there to give a service, you are going there to receive one, and to try to ground the conversation in one of gratitude and humility instead of altruism, I think is a very useful starting point.
So we had some people over on the side too who were going to ask questions.
Thank you.
So it's been a little bit, so my question's kind of reforming. But there's been a little bit of talk about who should be doing, I guess, there's a lot of work involved in kind of roping this or taming it. And I wanted to hear maybe from some of the people who work for NGOs or who've even run summer programs themselves on the American side? Is it the anthropologist's job? Is it the host country's job? And how much work should they be willing to put into it, or what should they be getting out of the work that the excess work that they'll be doing for the benefit really of the American students?
It's a good question. I mean, I think obviously working collaboratively is the best part. As a physician, working and trying to coordinate programs, I think the opinions and the help from the anthropological side have come very much in handy. But at the same time, sometimes you do need outside help in terms of international help, because a lot of local, how can I phrase this? The availability of anthropologists and people willing to work on specific subjects is sometimes not something that we have. And so in terms of capacity from the outside that we do need and people that we do want to help inform our projects, then that would be something that would be very, very good to collaborate with. So having anthropologists from the outside working in Guatemala and helping inform our programs, just like you are, is very, very helpful, because these are most of the time things that people, I'm a physician running a program, and it's not really my expertise to look at the cultural side. I look at the medical side, and so having that collaborative process is very, very important. And I would say that the third element, or the third person that I consider essential, is having, for example, as a physician, you were mentioning the power differences. You have to be very, very aware of those. And I not only have the power difference, but I'm also from the city. I'm very, very different. So having a local physician, a local nurse is who we work with, are from the community. So I think that is very, very important in helping inform our projects and our programs. And I think multidisciplinary is always the way to go.
So in my experience, we had kind of two different programs. We had a relationship with Princeton where they would send undergraduates, and they would send an anthropology professor, or postdoc at the time, Peter Locke, who's now at Northwestern, and that was really the ideal arrangement. And he would supervise them. He had had a sort of extended relationship with the region beforehand, guide them in reading, therapy, critical conversation. That was perfect. In terms of kind of what I thought about balancing when hosting clinical volunteers as the director of an NGO was, of course, one, what service would they provide in line with our mission in terms of concrete clinical care, et cetera, what could they bring? Two, the financial issue of capital's a kind of uncomfortable one, but was one that I really had to reckon with, because that brought a substantial amount of money into our organization that we could then redistribute, is the way I would think about it, from academic medical centers and their coffers to food for patients, medicine that could actually sustain real work. And that was, we had to put in the resources to make the volunteer system work, but that was opportunity cost we were willing to take. And then three was, and this is I mentioned, is I think our team thought that there is value in facilitating these engagements. I call them ethnographic engagements, but you could call them global health tourism engagements, in producing more complicated thinkers about these issues who are committed to our organization, but also into thinking in more nuanced ways about global health disparities, and that in and of itself is in line with our mission. And so that was also something, we were within reason willing to put resources and time and staff to helping facilitate that. So that's kind of how I think about this issue of balancing the resources required to adequately facilitate a program like this.
From an institutional point of view, I think of two things. One, the third party, I think, is really tricky because you don't have much control when it's a third party provider. if it's your students going. If it's your students going, I think the institution has a commitment to all parties involved to be very critical and proactive in their relationships and their collaborations, and they need to be interdisciplinary. So in our honors college and our study away and study abroad, this will become a fundamental component of how we approach our study away and study abroad, but also our service learning. And as the person who gets to pick the faculty, what I would love to see in a medical service trip is I'd like to see, it doesn't need to be a med-anth, but it could be a med-soc, med-hum, medical humanities. There are so many different disciplines that take critical theory approaches to humanitarianism and to healthcare and healthcare inequality, structure agency, all those things. So I think you need that, but I also think you need a healthcare provider, teacher, like a Claire, to go with you, because there were so many things that I could not advise the students on, and they needed that clinical expertise and authority. Now, we had it when we went back to the med school faculty, but they weren't at Monterey Tech, but our students weren't comfortable enough to talk to those faculty and admit that they couldn't do something or they weren't able to do something. And so I really think if I could have my ideal faculty team, it would be 2, and it would be a humanities/social science prof with a healthcare provider, teacher as well.
I'm just going to chime in on very quickly, specifically on the question, which is about the first part is whose job is it, and what should they, what should be the compensation for time used, right? And just being cognizant of the fact that a lot of these partnerships that we have for global health travel, even if they really work on a basis of reciprocity, that when we have a partnership with another institution, whether that's a healthcare facility or a university, that those are people whose time we are stealing, and they deserve to be compensated for their time. And there's going to be culturally specific ways of doing that. So the program that we ran, we realized that that this is a learning opportunity. It's a learning opportunity for both Tanzanian and Northwestern students. That it may be useful, but also they were going to take time in asking questions away from those healthcare practitioners in particular that were working in communities and that kind of thing. So what was appropriate there was I actually ensured that there was some compensation that was put to the institution, and that made a lot of sense because that particular institution has a team of people within the institution that decides how monies are allocated. And they've tried a few times to tell me how they were going to spend it, and I said, no, this is, basically your honorarium to say thank you for taking the time out, and then they can spend it. I mean, if they want to use it on petrol or tiles or it doesn't matter. It's compensation. We wouldn't tell them how we're going to spend our honorariums. So that was something that they liked, that we tried to minimize the amount of time of theirs that we were stealing, and that we were appreciative of their time in terms of bringing in some funding for them that they didn't otherwise have access to.
Next question? Yep.
Well, thank you for your time, and all your discussion points have been really inspiring and motivational, and they haven't left me disillusioned about this whole field, but actually motivated to continue working in it. So I was hoping that maybe you could all share some more self-critical and vulnerable experiences that you've had with missed opportunities for participants who've been engaged in this work, but who have become emotionally disengaged or gone through some type of mental stress, and how I think that's kind of intrinsic to a lot of these experiences when you bring people over, whether they're undergraduates or clinicians, that there is that 1 or 2 people when going through this experience that they kind of lose their conscious affect. And what are some missed opportunities that you've seen in that?
He doesn't want to start? All right. I'll bite. I'm not sure that I would call them missed opportunities in the cases that I've seen in the students that I've brought. Some things need to percolate a little longer with some students than with others, or with some practitioners than with others. In a particularly, when you take apart someone's life. It's my favorite part of one of my evaluations from students. She takes the whole world apart and she doesn't put it back together again. For some people, they sort of are able to engage, or even you've already taken it apart before they go away, and then when they come back, they've sort of got a messier understanding of things. Other people just double down. And sometimes it might take them a few years to sort of reconsider their position, or they might never. And so I've had some students that I've brought where the one thing that I've had a tremendously difficult time with is white privilege. And it's not just white privilege among white students, but because even among students of color, when they go, because they're coming from the United States, their privilege is sort of enhanced in a place like Tanzania. And so we've worked on a lot of critical reflection pieces. Sometimes that can work, sometimes it's a bit complicated. But I've had students that have gone and then a couple of years later said, actually, I've rethought the entire way that I engaged while I was there, and they just weren't quite there yet. And I've had that with full-blown adults. You know, somebody who was a policymaker, a politician who, not in the United States, who was going to make a stand on something that he felt was wrong, and he was, it was about a minority in a minority group in my home province of British Columbia, which Nicole lives in. And I said to him, if you're going to crack down on this with policy, you probably ought start with the humility of understanding what's going on with it, and maybe you should commission some researchers from that community to actually do some research to understand that problem before you crack down on it. And his response was, sometimes you just have to crack down on things on principle. And I said, well, yes, but white men have been doing that for a really long time, and the world's a big mess, so maybe you've got to try something else. And it ended up being quite a heated discussion, but it was 3 years later that he told me he never took the policy forward and had actually started looking at ways to find people with the expertise to do more research. So it's another thing where sometimes we can put our voice out there, we don't know how it's going to be picked up. So that's my response to that. It's not really a missed opportunity per se, as much as just an acknowledgement that not everyone's going to get it on the same timeline. I don't know if others want to.
Let me tell you a story about a missed opportunity that went from, I think, the sort of interpersonal interactions that Noelle so beautifully described to the point of having concrete institutional ones. And that is that one of the things I was looking at in Botswana was a pediatric clinic that at the time was run by the government but was staffed by a combination of Botswana nurses and American pediatricians. And this is also a story that sort of illustrates the extent to which the details really matter and how global health, quote unquote, plays out in all of its specifics. And that is that when the first cohort of very young, fresh from residency, eager to demonstrate that they were not under anybody else's thumb, American pediatricians arrived in the clinic, they arrived at a moment when the American associate director, who had been there for some time and knew a little bit about the hospital, knew the lay of the land a little bit, perhaps could have given them some orientation, was out on maternity leave. And nobody really gave them any kind of orientation. They were given like a month sort of crash course in managing pediatric HIV in the US and then distributed in countries around the world with no language training, no cultural orientation, nothing. And they didn't know thing one. They would show up in the clinic at 7:30 in the morning and take their files and go to their offices and go through their consultations, not realizing that by bypassing the act of greeting their Botswana colleagues, they were conveying some pretty antisocial sentiments, right? Like beyond the pale of just kind of frostiness. And it was 6 months after they'd arrived there that one of the nurses sort of mentioned offhandedly to one of these American pediatricians, this was a group of about 8 or 9 Americans, that all of the nurses had just come kind of axiomatically to the conclusion that all these pediatricians just hated black people. because from the point of view of the nurses, that's the message they had conveyed, right? It wasn't even like, do you like black people? It was like, oh, we've been watching you for a while, right? We've been studying you, we've been trying to figure you out, and we've come to the conclusion that you just hate black people, right? The profound misunderstanding here was damaging not just at an interpersonal level, but shaped the quality of interaction between clinicians who, to give them all the biggest benefit of the doubt I can, had the best interests of their patients in mind, right? And yet somehow found themselves in this incredibly toxic environment, sort of due to nobody's real ill will. I would call that a missed opportunity.
Someone else? So this is my own personal opinion, so please take it as such, but I'm personally of the opinion that there is no way to engage seriously with global health and not encounter these deeply uncomfortable moments of self-reflection and self-criticism and even crisis. And there's no way that you're not going to mess up. And if you ever come to a point where you're 100% sure that you know what you're doing, that you have all the answers, and that what you're doing is right, then there's a very good chance, in my opinion, that you're probably doing something wrong. But I think that it's these moments of personal failure and the reflection that comes from these missed opportunities and what you should have seen but didn't, and what you should have engaged with and didn't, that create the most powerful moments of possibilities for not only for change, for even programmatic change, because you notice things that you wouldn't have noticed otherwise, but also for changing who you are, not only as a practitioner, but as a scientist.
That sort of reminded me one more thing that I'd like to add, because I think you're getting at sort of the crisis that students face when they sort of face the critique and they're feeling a little bit alienated. And I get a lot of students that are starting to say to me things like, I'm not going to do this particular thing because it's not going to be perfect, or I don't want to engage in some sort of experience or some sort of engagement where I might make a mistake. And I say that's a profound shame. And actually tell them, it's important to be ethically engaged and to be self-reflexive and all of those things that we teach you, but also sometimes you have to be in the belly of the beast to understand how it works. And that's the best way to advocate for the kind of change you want to see. And if you're speaking to someone and they're really staunchly grounded in their perspective of things, and you're trying to help them hear what you want them to hear, then sometimes the first step is to demonstrate that you have a very profound understanding of where they are. And so this is something that I actually use a lot to talk about activism. And I'll say to my students, you are currently outnumbering the baby boomers. So the question you have to ask yourself is, what system do you actually live in, which is very depressing? And then from there, what do you want to build?
Thanks for this presentation. I teach at a liberal arts college that has a confessional mission, and I've got lots of students who've been involved in these short-term mission kind of trips. I've studied that, wrote on it in 2012, and focused particularly on the narratives. This is what was most striking to me, is the way that they would go to all these different places and then come back with essentially the same story of what they did. And some of you have already mentioned the ways in which poverty gets sort of flattened out into a common thing wherever it is, that all these different trips tend to take on the same sorts of tropes of poor but happy and simple, and I wish I could live like they do, and so forth. So I focused on the narratives, which I found had, I think, predictable effects of depoliticizing the context they went into, of obscuring, making it more difficult for many of them to see the particularity in the places where they were. And then even when they were troubled in the trip itself, when they came back in the representation of these trips, there was a kind of pressure to fit it into the narratives that they had begun before they went. And so I'm wondering with medical missions in global health, if you have found that there are linguistic and narrative shifts that you are making, the interventions that you've tried to make, and then also in ways that you represent these trips in the recruiting and the display of what the work is, if there are things that you have found or that you're trying to do to shift some of what's been going on in the past.
You have that great article on.
Who, me?
Oh, no.
No, her.
Claire.
Which one? There's so many.
Silencing, yes. Silencing of nuance.
Yeah. I've also written on that. I probably cited your work. I can't see your name from here, but yeah. It'd be great if more students could read that article. It's really sort of talking about the sort of this flattening or silencing of context in some sense. In terms of interventions that have worked, is that sort of where your interventions? There's a really great resource out there, a website called globalsl, which .org, which is global service. It stands for Global Service Learning. Maybe some of you have come across it. And the people that are doing that website, Eric Hartman is sort of at the heart of it, and it's not medical, but what's really great about it is that they really have a sense of like, how do we help practitioners, students, academics, and others come up with programming that really is based on a notion of equity and meeting need where people state their needs are and ensuring that there's local ownership. And there's a lot of universities that have actually sort of picked this model up of an engaged service learning or engaged community learning. And the idea of engagement is that we are sort of humbly in assistance of what people are already doing. Mm-hmm. There's not this presumption that people aren't already empowered, right? That's the bit that I always find interesting is how do we empower people to fix their own lives? And it always presumes that people aren't empowered, that they don't have ideas on how to fix their systems or their lives. And I haven't found any of those people yet, but if you meet one, then you might want to ask them, so what are your ideas? So Global SL is really trying to help people figure out, how to shift that mindset away from this notion of I can fix it to a notion of how do I partner? But even then, they should be made aware that that model isn't going to be perfect. You might find that you have an organization that really does this community engaged model, but when the students get there after a lot of training on like just ethical grounding and cultural humility and even on the place that they're going, they get there with a spirit of partnership truly in their heads and their hearts, and they're really wanting to work with others, only to realize that the organization that they want to work with is just busy. Like they just don't have time, and that such things do take time. And to realize like at that point you could still be learning to help reframe what failure is in their head. If they don't come out with some sort of shiny product of how they've helped something, then they haven't done anything. And I don't think I think that's a really difficult expectation to put on young people. And I try to talk to them about the fact that, you're learners first, and if you're doing it in an equitable way and you can't help your partners get to the table because they're just too busy, then ask how you might help be able to lighten their load. And maybe there's a way that you can do it, in the case of the health facility where I am, moving patients or folding gauze, right? Things that you don't need a particular skill set to do. Are there ways to do that? And if not, try to learn as much as you can when you're there, so that if you go back and when you go back, you can maintain ties in a much more meaningful way. And I do try to emphasize that longer term connection. That's what, at least in Tanzania, that's what people are looking for. I've got WhatsApp, you've got WhatsApp, okay, great, let's stay in touch. And that connection is actually quite meaningful for them. So I think also just shifting the expectation of what does learning look like, or what does help look like, or what does partnership look like, and helping them realize that failure is often part of that as well, and that failure is still a form of learning that can inform improvements on your approach later on.
Before students go, some thought experiments can help. So sometimes saying, I teach in Wisconsin, so sometimes saying, like, okay, if you had two University of Dar es Salaam students coming to your hometown in rural Wisconsin to help you with your terrible health outcomes there, how would you want them to proceed? And what kinds of things should they know? And that can sort of help shift, right? Because that can help them think in a slightly different way. And then I wanted to second Noelle's comment about long-term follow-up. And again, I need to be really upfront about this. I do not lead these things. I have so much respect for those of you who do. But I've been honestly too intimidated by the prospect. But I have talked to students. I have happened to be there at the same time with med students who are doing this, and have talked to people who in some crisis situations and such. And the idea that, like, make a friend who's local, who's kind of structurally similar to you, a med student or pre-med student. Stay in touch, like, have the hard conversations, and, like, expect them to be hard, and continue those conversations after you get home. That can be helpful too.
And excuse me, your comment about narrative, I find striking, because I wonder to what extent this sort of homogenization of the stories that they tell, right? They go to all kinds of places and they come back and they tell the same story. Sometimes I wonder to what extent some medical anthropology literature contributes to this, right? In the sense that I wonder to what extent they are framing their stories in terms of generic expectations, right? There's you kind of, like, the where you go kind of becomes irrelevant in the story, right? Like, as long as you can tell it in a particular kind of way. And I wonder, I mean, I think long-term engagements, and frankly getting to know somebody long enough to let them destabilize that story could be helpful. But maybe just drawing attention to the storytelling itself, right? What happens when they realize that they're all telling the same story, right? What happens if they're forced to narrate it in a totally different sort of set of genre conventions? One of the most productive writing exercises I ever did in grad school was to sort of read Hayden White on tropes and then write the same field story from multiple sort of White's tropes, right? So write it as satire, write it as comedy, right? Like, what happens if you try to tell the story differently, right? All the ingredients are there, right? But it's a really powerful, and I think to a certain extent, it's reinforced by the stories that we ourselves tell.
So I'm very aware of time. We're coming to the end. Was there one more question? Okay. Would you like to stand up?
I want to thank the panel for this information you've given to us, the audience. I just have two questions. Sorry I came late. One is, I am an associate professor of neuroscience at the American International University, St. Lucia. I'm a Nigerian, I'm a trained physician, and I have a PhD in anthropology in Nigeria. I want to ask, how do you say this is where I will travel? How do you make schedule for your travels? As in, which part of the world do I intend to travel? How do you choose? Is it a random stuff, or based on this, or based on connections, or based on, that is one. The other aspect of it is you travel. Do you get the expected outcome of the travels? Because there's one thing for you to say, I'm traveling to point A, this is what I want to achieve. And at the end of the day, because of some of these encumbrances we have anticipated that are coming out, do we come back after reflecting, do we say, oh, what I went for, I actually achieve it? Okay? Now, if we don't get what we expected to get, what will be our next line of action in terms of the expected outcome that we intend to get in each of the travels that we make. Thank you.
I'll start on that one. Okay. So I don't know if you were here for my part, but I did our clinical tourism study abroad to Guadalajara, Mexico, and it was a specific connection between my university and the university in Guadalajara. And it was part of a larger university initiative to create faculty and student exchanges and also binational research opportunities. And my experience in research is both in the borderlands of the United States and Mexico and also in Mexico itself. So mine was both because of my university partnerships and then also my personal engagements and professional engagements with Mexico. But above and beyond that, it's also my commitment to my institution as an Hispanic serving institution, largely of Mexican-American descent and Mexican descent populations. And those, I believe in creating experiential learning opportunities for our students that resonate with their lives. And so we have a number of pre-health professional students that have heritage in the borderlands or in Mexico. And so to me, it was also a commitment to my students to do that. With respect to did we achieve what we wanted to achieve, partially, but not in a way that I felt was sufficient. And so my response was to table the program until we could remedy those, in large part working more extensively within the community and also doing clinical skills training and humanities training and ethics training prior to the trip.
Thank you. That's a great question. Anecdotally, I can say that in Nepal, for example, the medical treks and health camps that are run are largely run in October, the middle of October, right after the monsoon season is over, when the mountains are coming out, the clearest part. So I can say that what I've seen a lot is very seasonal decisions around when it is either most convenient for practitioners from the U.S. to go, or based on kind of calendars of the academic year, kind of around students' opportunities to go and schedules. So I think the when, the where, and the how, I think is a good question to ask, and it is often a one-sided one that's often made not in discussion or collaboration with partners, and I think that's a really great push. The evaluation aspect, it's a really good question. One thing I guess I've always, it popped in my mind as you were asking it, one thing I've led over the past 2 summers exploration seminars, so month-long study abroad programs to Nepal, and one question I always ask is, looking forward with these students is, did one student choose to go back at any point? If you can kind of flip one student, flip that switch or one, I think it's a really interesting question. I don't know, I'd be interested to hear, maybe we can talk about it after the panel, but what makes somebody have that kind of moment of radicalization or that thought about, or kind of move away from the, oh, poor, they're all poor but happy, or kind of, wow, my whole world has been turned upside down, a really important kind of productive period of destabilization. I understand my own privilege and I kind of bring it back. So one thing we've done with the students is ask them to write themselves a letter before they go, and then they kind of mail it to themselves when they get back, and they can write it to themselves or they can write it to an object or a thing, but it's an amazing kind of moment of reflection that we all kind of get together and share, and it's always incredibly powerful to have somebody read their letter out loud and kind of reflect on it as a group. So it's a really good kind of disorientation after coming back, and kind of as others were saying, kind of stay with those periods of instability and kind of wrestle with them. So it's always nice, but yeah, those are great questions, and I really want to think about that more now.
I hate to keep coming back to the money because it's never a fun topic to talk about, but at least in the case of Guatemala, for example, where you have very much, what Scholler would call a republic of NGOs, where you have over, the last estimate placed the number of NGOs in the country at over 10,000, which is about 1 NGO for every 1,500 individuals in a country roughly the size of the state of Tennessee. And it gets even more interesting because those NGOs, many of which run short-term medical missions or some kind of mission like that in order to fund many of their programming or to recruit donors. All of those NGOs, almost without exception, are clustered around either Antigua or the lake. And so you have the prettiest, most accessible, most touristy areas of the country that are completely and utterly saturated with programming. And then you have the rest of the country where the need really exists that goes without. And so it comes again to this question of when you ask, are we getting what we expect? Are we getting what we wanted? Who are you worried about when you ask that question? Are you asking, are the students who are going on these things, are they getting what they wanted? Or in terms of their own experience, the package that they bought? Or are the people that they were hoping to provide services to, are they getting what they wanted? And I think you can just look at the geographic distribution of the programming in my country of experience, at least, and you'll have your answer.
We are out of time, but I just wanted to thank all of our panelists and everybody in the audience who came and participated in this conversation. And hopefully this is a conversation that begins here and that we can continue with forward. So thank you so much.